My name is Nathan Wong. I'm a professor and director of the Heart Disease Prevention Program at the University of California, Irvine. It's always a real pleasure to participate in the International Academy of Cardiology World Congress on Heart Disease. And this year I was privileged to have the opportunity to present the Jeremy Swan opening lecture, which was on the topic of the ACC-AHA guidelines for cardiovascular disease prevention and the interpretation of it and future directions in prevention. As we all know, the American Heart Association and American College of Cardiology released 4 major guidelines in cardiovascular disease prevention in November 2013. They included guidelines on cardiovascular risk assessment, lifestyle management, obesity management, and the cholesterol management guidelines, which got the most attention. We always begin efforts in preventive cardiology by talking about cardiovascular risk assessment. And the cardiovascular risk assessment guidelines have recommended the use of a new global risk scoring algorithm called the pooled cohort risk score that estimates the 10-year risk of atherosclerotic cardiovascular disease, including myocardial infarction and stroke. If the treatment decision is still uncertain based on this global risk assessment, then one can consider stratifying the person's risk to better inform the treatment decision by evaluating the individual's family history of premature cardiovascular disease, also whether there are several additional tests, including measurement of high sensitivity C-reactive protein, measurement of coronary calcification, as well as measurement of the ankle-brachial index to detect peripheral arterial disease. If these are positive, namely if there are one or more first-degree relatives that are affected with premature cardiovascular disease, or an individual has a coronary calcium score of 300 or higher, or greater than the 75th percentile for age, gender, and ethnicity, or a low ankle-brachial index, less than 0.9, indicative of peripheral arterial disease, or a high sensitivity C-reactive protein of 2 or greater. This may better inform the clinician to stratify the patient's risk upward for consideration of preventive therapies, including statins or intensification of therapy. The lifestyle management guideline has focused on a dietary pattern that emphasizes the consumption of fresh fruits and vegetables, high grain products, and avoidance of sugar-sweetened beverages, and as well as consumption of low and non-fat dairy products. In addition, the obesity guideline pointed out that even modest weight reduction of 3 to 4% can have significant benefits in terms of reducing cardiometabolic risk factors such as lowering blood pressure or improving lipids and prevention of diabetes as well. The guideline that got by far the most attention, however, was the cholesterol management guideline. And a key feature of this was the definition of 4 statin-eligible groups: persons with atherosclerotic cardiovascular disease, persons with an LDL cholesterol level of 190 or higher, which may indicate familial hypercholesterolemia, also those who have diabetes. And the fourth group, which was the most controversial of the statin-eligible groups recommended, are people in primary prevention who have a 10-year atherosclerotic cardiovascular disease risk of 7.5% or greater. This cut point was chosen based on the placebo groups of 3 primary prevention trials that show the efficacy of statin treatment in this population. There has also been recent data to document the incremental cost-effectiveness ratio to be suitable in persons with a risk of 7.5% or greater. The other important feature of the guidelines was that there is no longer a recommended LDL cholesterol level for both initiation or for use as a actually goal of treatment, because the randomized clinical trials really demonstrated that they did not prove whether one specific LDL target was better than another. Namely, they have focused on the use of higher versus lower intensity statin therapy, and that is where the evidence base is for which these guidelines have made this recommendation. In addition, it's important to point out that regular monitoring of lipids is still recommended to judge adherence to a statin. For example, a high-intensity statin is supposed to provide at least a 50% reduction in LDL cholesterol, a moderate intensity statin, a 30 to 50% reduction. If there is not a satisfactory reduction in LDL cholesterol, perhaps due to statin intolerance, or some people simply don't respond adequately to statins, there are non-statin therapies that can be recommended for consideration. For example, ezetimibe was recently documented in the IMPROVE-IT trial to provide added LDL cholesterol lowering and further risk reduction in high-risk individuals with acute coronary syndrome. There are also other therapies that have recently emerged for the treatment of familial hypercholesterolemia, and perhaps the most exciting story in preventive cardiology this year is the recent release of some of the newer PCSK9 monoclonal antibody agents. For example, Alirocumab was just approved in Europe for a variety of indications, and just the other day in the United States, the FDA approved Alirocumab for individuals who in particular have heterozygous familial hypercholesterolemia, or those who have atherosclerotic cardiovascular disease, who are on maximal therapy but do not achieve adequate LDL cholesterol lowering. There is also the expected approval shortly here in the US of Alirocumab as well. So these products now offer the clinician important options for addressing remaining lipid residual risk to ensure that our patients who have been identified by the recent guidelines are appropriately managed and treated. I think it's very important to recognize, though, that these guidelines we're talking about, they are evidence-based, but remember that that the clinician should not feel bound to these guidelines, and ultimately the individual clinical decision making by the clinician is key in individualizing treatment while recognizing the evidence base for which these guidelines have originated from.